Okay, we're going to get started.
Yeah, but we can't get to the Cover Oregon website.
Yeah.
We're going to get started.
That topic is the off the table today.
My mic. Is my mic? Can everyone hear me?
Yes.
Waiting for the gentleman to give me a thumbs up. Okay. So welcome to the OHSU Department of Medical Informatics and Clinical Epidemiology seminar. We are thrilled today to have Lori Koiner with us. And this is being streamed. So if you want to send us a tweet, for those of you out in the world, you can do that by sending it to @OHSU Informatics. You can put a hashtag, but we'll follow it. If you want to use the hashtag DMICEConf, C-O-N-F, then we are happy to see those as well, but @OHSU Informatics. So I'm David Dorr. I'm the Vice Chair of Clinical Informatics in the department and an Associate Professor here. And this is a topic that's very near and dear to my heart in a lot of ways. So this is a great sort of way to think about the way that informatics is affecting a lot of our healthcare and healthcare reform. And we're thrilled to have Lori Koiner here today, who is the Director of Accountability and Quality at the Oregon Health Authority. So she sits in the director's office and reports to the director and really focuses on all the aspects of health reform that have to do with quality measurement, quality improvement. So she's going to talk a little bit about what's going on in that world with the coordinated care organizations and all of the different aspects, meaningful use, that are health information exchange, that are happening there. And then I'm going to talk a little bit about an informatician's view of this, sort of from the work we do at OHSU and as informatics, how we think about advancing this work based on what the health reform is bringing. So, Lori?
Thank you. For those of you who've been around the informatics world for a little while, my name was formerly Lori Lambert, and I taught the introduction to biostatistics for a lot of years for this program and for the MPH program. So my name's changed, same person, same poor jokes. So I wanted to check, are you going to be advancing slides, or should I just do it from here? Okay, I can do it. The title of my talk today is Where Oregon's Health System Transformation Meets Informatics. What I'm going to go through today is I'm hoping a little bit of a stepwise talk. So I'm going to give you a little overview about what health system transformation is from the health authority's perspective. Then what measures we need to do to measure whether that's working, and then how those then relate to the HIE strategy that the state's working toward, and then David's going to get down into some details about where that gets complicated. So the health system transformation was first thought through by our Governor John Kitzhaber, and the health authority started by developing what are called CCOs, that's coordinated care organizations. And the model of those has been described as ACOs, or accountable care organizations on steroids. So and the reason I think for that is that we have a very fast implementation plan. The first CCOs came into existence in 2012, late 2012, and the first year that we're tracking with measurement is 2013. But to think a little bit about what the model is like, there's a big push to integrate services. So rather than the kind of old-fashioned managed care organizations that just focused on physical health, mental health services are now rolled in, and dental is being rolled in January and July. So now these coordinated care organizations will be responsible for mental health services, physical health services, and dental services for their clients. And they're given one global budget to do that. The global budget will grow at a fixed rate each year, so they know how much they're getting next year, and they need to operate within that budget. However, they're given lots of flexibility on how to do that. There's work, we have line items for flexible services, for example. So we heard from a CCO that had a patient who was down in the southern part of the state. He broke his leg. He was living out in a trailer far from any services, poor nutrition, not clean. They were going to amputate. So the CCO found out about it. They paid for housing. They paid for him to move into town and get regular services and some nursing visits. That kind of care is what's being promoted, so that housing service doesn't get dumped into administrative costs. It's put in as a line item of flexible services. So we're trying to change what the model is of healthcare, so and add for local flexibility. Then the key component and the major piece that I'm going to talk about is this metrics over there, the orange box, and they're serving two purposes. One is that the state is on the hook with CMS to show that we are not degrading quality, but in fact improving it over time. And then the other purpose of the metrics is to pay the CCOs based on their performance on incentive metrics. This map wasn't intended to be able to read all the CCOs, but it's just to show you where they are. There are 15 of them. The darker green shaded areas show you where there's more than one CCO. So OHP members have an opportunity to sign up for one or the other. But a good portion of the state, there's only one. And Eastern Oregon CCO covers, I can't remember how many square miles, but it's huge. And it's mostly rural providers. So they really vary in terms of their service population and what their delivery system looks like. Here are the main tenets then that when we made the negotiation with CMS, that we are on the hook for. So the first is to reduce the annual increase of the cost of care by 2 percentage points a year. While we do that, we need to ensure that quality improves, population health improves. We have established what's called a 1% withhold. That is the CCOs are paid that 1% when they report their claims in a timely manner, and that has partly to do with our ability to measure. If the claims are coming in a year late, then they kind of miss out on our quality measurement. And then to establish this quality pool and the methodology by which we'll pay on the incentive metrics. So we had to develop a quality and accountability plan. This is the part that I oversee, and it was part of the $1.9 billion agreement that was made with CMS for this health system transformation. One is a quality strategy, so that tells how we're going to improve quality. The state test for quality and access is 33 measures that we need to track over time. We actually have an independent entity calculating those, Quality Core, and they then we start losing funds if we either, for the first 2 years, we have to keep quality the same, then we have to start showing improvement, and the state will lose funding from the federal government if we don't show those improvements over time. We have a detailed measurement strategy, and then this quality pool incentive payment program. The kind of tenets around this, we have a transformation center, which is housed in OHA. It has innovator agents that are embedded in each of the CCOs. It's built on the model of agricultural extension, where they're experts. They come back together and discuss issues the CCOs are having and try to spread best practices. The transformation is all center, and my office develop learning collaboratives, which are focused mostly on peer-to-peer learning and rapid cycle improvement. Each of the CCOs is required to have a community advisory council made up of patients and members. There's an approach to add non-traditional healthcare workers, which means lay health workers and figure out ways to get them paid. And then there's a real emphasis on patient-centered primary care home adoption. So the 33 metrics that I talked about, those are the metrics that we need to show maintenance and an improvement of quality. And they fall under these 7 focus areas. So the first, and I mentioned this earlier, is an integration of behavioral and physical health. Because the population is primarily women and children, there's a focus on improving perinatal and maternity care, reducing preventable rehospitalizations, ensuring appropriate care is delivered in an appropriate setting, improving primary care for all populations, There's one focus area on high-cost patients or high utilizers. We have a collaborative on what we call complex care patients. And then finally, a focus on some chronic disease, such as diabetes and hypertension. So I said there was a big measurement strategy. The 33 performance measures are the state test and quality and access measures. 16 of those are also the incentive measures. So we do have overlap. There's one additional of the incentive measures that the CMS wasn't interested in, but we thought was important. We also have 16 core performance measures that we have to report to CMS. They are what I consider a bit more transformational than some of the other measures. They include rate of contraceptive use for women not desiring pregnancy, BMI, tobacco use, and some things like that where we're really working and thinking about how to collect and report. And then we have two CMS grants, the ACHIPRA for children and the Medicaid Adult Quality Core Set that we're reporting as part of those grants. And then we have over 100 measures that we have to report to the U.S. Department of Justice for patients with severe and persistent mental illness. So how did we come up with our incentive measures? The Senate established a metrics and scoring committee, and this committee met a lot at the fall of 2012 and came up with a measurement strategy for what measures would be in the quality pool and how that quality pool gets distributed. I'm not going to spend a lot of time talking about this. If people are interested, we do have the whole quality pool methodology posted online, and I can send David a link to that. But it was a multi-stakeholder group. They worked with an outside consultant that came up with, who recommended less than 20 measures for a pay-for-performance program and came up with 17. And then they came up with this quality pool strategy. I guess the quick things I'll tell you about it, it's considered a bridge strategy from moving from capitated payments to payments for outcomes. Though most all the measures are process measures and not outcome measures, the idea is that the Metrics and Scoring Committee, which is still meeting every other month, we examine the measures, kind of look at progress, highlight difficulties, adjust benchmarks, and eventually hope to move to outcome measures. The pool size is based on 2% of each of the CCO's PMPM, so in terms of what their billed charges are. And then it's distributed based on enrollment and kind of a pass-fail on the measures. So each measure is weighted equally. They either get a pass-fail. How do they pass? They either meet or exceed the benchmark, which is usually the 75th or 90th percentile for Medicaid nationally, or they meet an improvement target. And this idea of a concept of an improvement target has turned out to be a good deal. And it's developed on a methodology that was first started in the state of Minnesota, and it's based on where each CCO starts, their gap to the benchmark, and it's pretty simple. You just measure that gap, divide by 10, and that's the proportion that they need to increase each year or improve each year to meet their performance target. The idea was that that CCOs, if you saw our geographical distribution and the delivery system differences, there's going to be huge variation. And so the idea is that if each CCO meets their improvement target within 10 years, they'll be exceeding the benchmark. So here are the list of measures. You can look at the slides. I'm not going to walk through all of them. We have quite a few that are related to behavioral health. But the first one, screening for clinical depression and follow-up, well, let me take an aside. So I took this job almost exactly a year ago, and I had this list of measures. And so we've spent a big portion of time operationalizing those, because if it just says alcohol and drug misuse screening, brief intervention, and referral for treatment, that's a process often known as ESPER. But then the whole question came, well, how do we measure it? What do we measure? It's a completely new idea. We didn't have national standards for it, and we had 17 of these to figure out. So screening for clinical depression and follow-up plan, at first we thought we'd follow claims. We opened up some codes in our Medicaid billing, and then a lot of people just said this wasn't going to work across payers. So it's now a measure that we are going to be collecting through electronic medical records. That's why it's highlighted, because we're going to focus on that. We have a number of measures around maternal and child health of different stages of age. And then we have two other measures that are highlighted: optimal diabetes care and controlling hypertension. Those two comprise, with the depression screening, comprise the three that we will be having reported through electronic medical records rather than claims. So when I came a year ago also, the agency had planned to do old-fashioned chart review for these. The cost was huge. It was upwards of $1 million a year to get 15 numbers for each, 15 times 3 numbers. And we'd have to do that every year, and you just end up with a number. So the thinking was, if we're going to be investing funds into collecting the data, why not try to build something that's going to be moving towards electronic medical record reporting than just sending people out to do chart review every year. So once we started to work on that path, I started to work closely with Susan Otter, who's the director for HIT-HIE within the state. And a lot more of what I'm going to talk about is related to that. We also have some appropriate access measures, emergency department use. You may have read the article in Science. We're measuring ED use as we go now. And then a patient experience measure and one that's a measure of electronic health record adoption, which CMS felt strongly that we needed to create some sort of measure of that. So what is the strategy to collect and report these metrics? This is at the CCO level. We really had to think, what are we going to do and how are we going to do it? And the idea came, I guess, with three main thoughts. One of them is to phase it in over time. We know that Eastern Oregon CCO, for example, still has a lot of practices with paper-based records. We know that the Portland metro area has a lot of high EHR adoption level, but the problem is that their network is huge. So what we decided is we'd phase this process in over time and link it with the building of our HIT strategy. The second thing is we know that the meaningful use stage 2 standards are out, that electronic medical record vendors need to put the meaningful use stage 2 capabilities into their EHRs this year, and so we want to leverage that and the fact that we are going to have to collect data from those providers who want to meet meaningful use stage 2 for Medicaid. And then the third thing, as I mentioned, we felt that there was a new push to develop a statewide HIE-HIT strategy, so that we needed to couple this collection of EHR data with the strategy. So when I said we were going to phase it in, we had to go back to CMS and negotiate this. And so what's the plan? Well, what we decided was for 2013 year payments for CCOs, instead of paying for performance on diabetes and depression screening, we would just pay for measurement and reporting. So they have technology plans that are due February 1st that describe their network, describe their gaps and opportunities, and how they're going to collect a proof of concept sample. That proof of concept sample only needs to be represent 10% of their membership. Then in 2014, they'll need to update their technology plans and talk about how they've worked on their gaps. That's really what we're going to be focusing on. And then require them to send us an expanded set of data. We haven't really determined what that's going to be until we've had a chance to learn more about what's going on through their technology plans. And then the part where we really had to negotiate with CMS is they were not completely okay with 2 full years of only pay for reporting. So what we said is you get your quality pool funds if you report. If you want to be included in this phase 2, we have a challenge pool that's kind of leftover funds because we're committed to distributing everything. So for the challenge pool, if you turned in your data, then we will look at some kind of performance metric, and we have to build that. We have to determine benchmarks, and we're working on that now. And then finally, by 2015, we would be expecting full data reporting and then paying for performance. The the reason I have it in quotes there is I don't anticipate that we'll be asking CCOs to get all the data from all of their providers. So we're going to have to come up with some sampling strategy that we have not figured out yet. So just to give you everyone an idea and an overview, so what does this HIE strategy look like? This is what we're calling the near term or phase 1.5 of the development. And it has kind of a collection of pieces. The one that we're most focused on for the quality measures is this building of a clinical quality metrics registry. So by 2015, when people have to report their full data set, we will have a catcher's mitt, which is called the Clinical Quality Metrics Registry, to collect all the data. The other pieces that are included in the 1.5 strategy include a provider directory that going to have a lot of different functions and capabilities. Hospital notifications, what that means is if a patient arrives in the ER that someone, their primary care provider is notified. There's technical assistance that we are going to be paying for. We'll be putting out an RFP for that to help providers meet meaningful use stage 2 and probably learn how to submit their metrics into the Clinical Quality Metrics Registry. That registry is kind of a twofer for us. We will be collecting information either from CCOs or providers on CCO's behalf for the CCO measurement, but also that will be the vehicle by which providers submit to get their meaningful use stage 2 payments for Medicaid. So we have to build that anyway for the Medicaid meaningful use portion, so we decided to put it together. And then there's still a push for statewide direct secure messaging and a patient index. And as you can see, it says 2013 to 2015. We need to have that metrics registry developed and built by 2015 in order to collect information from the CCOs. So this just shows kind of how the whole strategy is going to work. We do expect that the clinical metrics database will require some kind of data intermediary potentially that would collect the data and maybe just send us the Medicaid. We have to still adopt standards for safety, privacy, and security, which it's causing us to really think about, and I think David will talk a little bit more about this. We're looking at having, for example, practices submit what's called QRDA formats. There's QRDA 1, which is at the patient level. There's QRDA 3, which is a numerator and denominator for the practice. We would prefer, in the long term, to get QRDA 1, but then you have to work your way through a lot of privacy and security issues. And then, again, we plan to align the metrics and reporting. This just shows you that we are collecting and making payments on Medicaid. This is where the state of Oregon stands as of fall of 2013. Medicare's paid about 3,200 providers and 29 hospitals in Oregon, and Medicaid, so the state agency, has paid 1,700 providers and 50 hospitals. Hospitals, for those of you who are not steeped in meaningful use, hospitals can apply for both Medicaid and Medicare. Providers have to select one. And this just shows you a map as of, it was last updated at the end of June, on EHR adoption or health record incentive programs within the state and where the eligible providers for Medicare payments are. So you can see it's not evenly distributed across the state. The light colors have less adoption. The darker colors have more. The dots are hospitals. So you can see out in Eastern, that light color almost completely maps to the Eastern Oregon CCO. And this is just a summary of EHR adoption in the state. It's actually, we're quite high for the country. And that's one thing that why we think we can leverage this approach. I do want to mention in terms of our technology plans, we are allowing CCOs, if they have it, some of them have local HIEs, they can submit that way. We have kind of an alternate format that they can submit if they have a large clinical registry instead of straight out of EHRs. So we're trying to develop that capability as well, because we are aware that not everyone's got full EHR adoption. And so, as I mentioned, some of the gaps, the geographic areas are vary. And the other piece that's going to be real challenging for us in the long term is that you may remember at the beginning of when I started talking, EHR providers, CCOs need to integrate physical health and mental health services, but behavioral health providers have very, very low EHR adoption rate, as do long-term care facilities. So that's going to have to be a long-term goal. So here are some opportunities, and I don't know if now is a good time, David, to talk about this, but I have spoken with David about opportunities for students who are looking for internships. And so here's a brainstorm of a couple. The first one, so I mentioned that we're going to be providing TA services for people meeting meaningful use stage 2 and for helping practices submit data. And in order to put that together and figure out what kind of TA people need, we plan to take a hard look at the technology plans that are being submitted February 1st. And then we've also found out that most of the CCOs, or at least many of them, have been sending out surveys of their provider networks. And we are going to ask them if they'd be willing to share. We'll compile the information and send it back out. But we think that between the surveys and the technology plans, we can learn a lot about where the state of the state in terms of reporting these clinical measures, where that stands and where the gaps are. And so that's an area where we think a student could come in and take a look at all of it, compile it, and then make some statements about or help us identify gaps and opportunities for technical assistance. The other thing, there is lots of thinking that needs to be done around privacy and security. We've had a number of conversations with other states in the country who are doing this. Connecticut, for example, is moving towards that QRDA1 or patient level. Most of the states are starting with numerators, denominators in their collection, their catcher's mitt, and then they plan to move to QRDA1. But thinking about the fact that when a provider submits data, it does not parse out payer type. So Medicaid's in there with commercial. How do we make adjustments for that? How do we think about privacy and security if we're collecting information from commercial? Do we need a data intermediary? Things like that. And then the last is the more details and helping us learn more details around the use of the QRDA and CCDA formats, what the opportunities are, what the challenges are, so that when we write our materials and start expecting people to submit, that we have a good understanding of what the limitations are. So I think that's all I have. David now can address further some of the challenges around collecting the data. Just real quickly, here's my contact information if you have questions. Susan Otters, who is overseeing the HIT-HIE strategy. And then also, that link up there is our metrics page. It has all of the specifications for every metrics, the quality pool methodology, and probably more than you'd ever want to know.
Great.
Thanks.
So what we'll do is I'll talk briefly, and then I'll actually put this slide up, and then we'll have a question and answers Is the microphone okay? Okay, great. So let me switch to. So, as you heard, there is an incredible amount going on, and there is, especially for health information exchange and getting the clinical quality measures, getting actually down to the patient level details so they can collect this and really understand clinically what's going on with these patients, and the care that's being delivered from that perspective is really advancing quickly. This has been an issue for a long time that we've based our clinical quality measures either on chart review or on administrative claims, billing, which in that sense the data is really collected for a much different purpose. It's to generate a bill, to justify that you saw a particular patient in an office visit, and in a mostly fee-for-service system, you're really just trying to say, I had this office visit, I saw this patient, here's why. And there's not as much that's specifically tied to the quality as we think about clinicians. Now, so I'm going to talk about this. I have sort of multiple frames of reference that I'm going to try to use. One is sort of as an informatician, what do we think about the standards and vocabulary? What do we think about health information exchange? What are some of the issues that come out of this? Where are the opportunities? But also I play a role here in the sort of clinical operations at OHSU. What's our experience in trying to look at some of these standards for the health information exchange, for sending electronic clinical quality measures, for meeting meaningful use, for participating in our particular CCO, which is, although we get patients, I think, from every single CCO, all 15, because OHSU has so much complex care it delivers, that what's our experience in working with our CCO and the quality of care as reflected back to us as we really think about how do we deliver the best possible care that we can and have that reflected in the measures that we send, and where do we need to go across that. So health information exchange, I think, is a really simple, and it turns out the electronic clinical quality measure formats really fit into this. They're really just, from an informatics perspective, there's collecting all the data about the quality you receive, but really what's happened is that we've started to define standards to stage that data to send it out. And there's a broad standard around that, but the goal is really at transitions of care, when you're reflecting the care you've given to a population of patients who might need a particular quality measure, that you're getting the right data to the right person at the right time through the right channel, much like clinical decision support, which is more just in time, right, as you're seeing the patient. This is sort of as somebody is thinking about this population or this individual patient at a transition or to reflect in the care that's been delivered for performance, what's happening or what happened. And so historically, we've struggled to sort of implement health information exchange. There's lots of value propositions here. When we look at some of the CCO measures, readmission risk, can that be mitigated if we send out this ADT, the admission information, when somebody shows up to an emergency department or hospitalization, out to the primary care provider, and they can get that right just in time and maybe prevent a hospitalization? Mark Frissy, when he worked in their health information exchange in Memphis, he showed that there was a value added in terms of reduction in costs when ED physicians had that right information and were able to communicate. They could say, I feel safe not admitting this person to the hospital, but sending them home instead with good follow-up. And so there's some real value that can come, but it hasn't spread. Indianapolis has done this for a long time. Really the whole state of Indiana now, sharing information, trying to figure out how we can better use information to make good clinical decisions about individual patients and populations. And so finally, sort of the country is catching up. There's lots of things going on now. But these standards have evolved so rapidly from an informatics perspective that it's very difficult to figure out what's going on. And I'll show you, in some ways the early adopters might be a little penalized now because you've got to retrofit what you did. But the good part about it is now we can sort of have a standard we can rely on and send out. So I'm going to give a bunch of examples around this, and I'll sort of go through them. There's a lot of acronyms. Tons of acronyms. Coordinated care organizations you heard about. So I'm going to try and define mine up front, and I'll say right away the first two, CCR and CCD, are basically all but dead. CCDA has become. So basically what we were trying to define as sort of informatics, as sort of people who are interested in exchanging data here, is what is the core set of data that's needed? What's the format that we could send it that's a standard that can go across to different places so it could be understood by somebody who needs to think about this patient at a transition and as it's evolved across a set of patients as a population. And so there was the continuity of care record that was defined, and then the continuity of care document that sort of tapped into HL7's clinical document architecture. And then finally, and really it's about 2011, 2012, we've got this consolidated clinical document architecture, CCDA. And it turns out, though, you can define standards all you want, right? But will this standard get taken up in a meaningful way? What are the motivators for this? Obviously, health policy and opportunity is one, but the sort of utility to providers and utility to the institution, the value that it adds in going through the step of implementing the standard and being able to receive it is really important. A lot of the potential, a lot of the initial step, the foundation, has been pushed to EHR vendors. As mentioned, EHR vendors are now required for certification to have this functionality. But a lot of where the rubber meets the road is implementation. And so we'll talk a little bit about that. And it turns out that the way we're talking about sending the electronic quality measures, either at the aggregate of the patient level electronically, for meaningful use, and for others that Lori mentioned, is through this specific kind of a CCDA called the QRDA, the Quality Reporting Document Architecture, which is sort of what about this patient or this population led them to be in the numerator and denominator and whether they met the measure or not, and that can then be easily rolled up. So it's just a sort of a special case. So now we've got a standard, right, that has, if I'm seeing this patient at a transition, what's the information I need about them in the CCDA? If I'm reporting my quality measures, what information do I specifically send, and what's the QRDA? And so we've got a standard, and the question is, how do we implement them? And the other part that's been really interesting is that because the EHRs have been tasked to have this capability, they actually said the EHR should be calculating this electronic clinical quality measure, or you can use an approved population management system. But you've got to get certified to basically calculate that. And so most places, and most of the EHRs mention, most of the implementations, they do it themselves. And so they do this through this health quality measure format definition that gets implemented. And I just have to say that the National Library of Medicine is helping to maintain the concepts that are part of all those measure definitions through the Value Set Authority Center, the VSAC, which is sort of attached to the UMLS project. So this is something now that I use really frequently in my work to say, hey, what are the set of codes for ICD-10 around CHF? What are the SNOMED codes for it? It's all maintained there and updated there across all of these quality measures. Really a valuable resource for everyone. I'll show a picture of that. So looking at the CCDA, there was a grant from ONC to Massachusetts to say, hey, is this standard going to meet our needs for health information exchange for the kinds of things people need to do? So the first thing they found out is that, there's a bunch of elements that are important. What they did is they basically said, what are the elements you need to do to take really good care of this patient, to add the value, to get the value from this document. And so in the initial format, there were 175 components, but they found 325 total components that are basically needed for the basic transition of care. And then if you're really taking someone over care over a long period of time, you need even more, 483 components. And so immediately it's sort of like, well, we need to have a staged approach because the initial definition of the CCD and the CCDA is just too narrow. Especially they were looking at both the definition and then also how it was implemented. So for the implementation of, at that time, the CCD, they said, you know, there's only 175. We need 483. You could add these other elements in the infrastructure. It's an XML sort of extensible infrastructure, but you have to actively do it. So a lot of work to really get the sort of core elements that are needed to take care of the patients. So you can basically map them in without difficulty, but there's a ton of implementation work. You can't just flip the switch and say, my CCDA is going to be useful to everyone, or I'm going to start receiving good information from anybody. You don't know what you don't know when the elements are missing to take care of a patient. So that's the first thing. Even if we turn this on and we solved all the privacy, security issues now, we have to think very carefully about what's missing. So a lifetime's of work for informaticians in this regard. Some do not have CCDA templates at this time, although they've since, of course, gone to HL7, and I think they've developed most of them. Now, I'm sorry, this is sort of a complicated slide. The only purpose of this is that depending on what you're doing with a patient, whether you're doing a care encounter that's shared between a specialist, a consultation request, you're sort of asking somebody to help out, or you're doing a big transfer of care like to a long-term care facility, it also varies. You don't need all 483 if you're just sort of asking a specialist, can you help with the cardiology? So there's work in sort of context and setting and these other elements. And one of the things that they looked at pretty carefully is there's really poor definition for those kinds of long-term care or post-acute care that's not in the home. So there needs to be a lot more help. Part of that's because most of them don't have EHRs, but that there's different approaches needed for that. And they developed this clever little land and sea approach where you could sort of share different aspects with those settings. They're working on that. So a lot of exciting work in that area that's really nice for informatics. And as Oregon comes along with that, that's the sort of things that we're doing. The other thing is that there are some immediate value for health information exchange. VA started to do this a long time ago, saying, well, if you're seen at a VA in, Portland, Maine, you should be able to get the data in the Portland, Oregon VA. There are different data structures. There was a lot of decentralized development of VAs, VISTA, and then CPRS. It since got centralized, but they figured out a way to map it and implement it, but only between VA sites, right? So then they got, hey, this is great for us, right? Because we've got this. And then EHR said, hey, let's do this. And so I've got a health system in Texas, should remain nameless. They use a particular EHR HIE type thing called Care Everywhere. Basically, they say this is what we use for HIE. This is the way we do this. But of course, you're only exchanging between two people who have the same EHR between the VA, right? You're missing a lot of information. And what's happened is people feel good. I now exchange information. I have achieved, this height, but they're really missing a lot. And as you saw in Oregon, there's 97 different EHRs, although the majority of them are from less than 10. You start to get into this implementation where you have to sort of rework. And I'll tell you, in Portland, because there's a particular EHR that dominates, people really like the HIE Lite, the Focus HIE that exists here. And so there's a lot of work to sort of expand beyond what your EHR has implemented. So early adopters or people who are innovative might get penalized. So this is work I do for my research. Mostly I do research in complex care management through Care Management Plus, and we've gone out into quality and quality measurement. And when we started our grants, we were doing a grant saying, well, can you randomize patients to improve quality, or clinics to improve quality versus randomize them to do care coordination type activities? Which of those is going to reduce hospital bed days more for complex patients? So we had to develop a whole quality infrastructures. We have about just under 70 measures that we've implemented in this, and it's used operationally, but we had to do it before there were any electronic clinical quality measure definitions. So, we sort of, we were innovators, and we did this, and we built nice dashboards. And, one of the things we learned in this is that when we brought on clinics from different EHRs, A, B, and C all have different EHRs, we get this weird result. You can see that their performance of this particular blood pressure control and diabetes is really variable, and it looks like Clinic A is really decreasing over time, like they are sort of going down. And it turns out the reason for that is that there's a lot of validation work that you need to do. And when when you're mapping it yourself, you're not relying on somebody else to do it for you, you can do that. So this is the way we do it here. We get feedback from the clinics. We show them the individual data with what the patient had, what the A1C was, or the blood pressure was, and then they can tell us, hey, this is wrong, you need to fix this, and then we can adjust our feed. When EHRs calculate it for you, you can't do that. You've got to collect the data the right way the first time, the way the EHR wants you to, or you miss the boat. So you can't adjust your feed so easily anymore. It's all sort of in the EHR. And we've done this with lots of different EHR systems, and each one is sort of a novel experience in trying to figure out the way they store the data. So they got pushed to do this all themselves. And this is my favorite graph because basically when we started this in 2009, nothing like this existed at all. And now it's all been developed. There were e-clinical quality measures, but they weren't implemented quite to this specificity. And basically what this shows is that EHRs are holding the definition of the E-measures, and they are producing the quality measures themselves. They are required to produce them through a calculation engine in most cases. I mean, you can have a certified engine that does it, but in most cases the EHR is doing it and producing these reports. And so it turns out, and they are producing the export format as part of what they're required to do. So they're doing the CCDAs and the specific QRDA types under that. And so because of the short time frame here, they've really had to throw this in, basically, and try and get it up and running as fast as they can. So basically, EHR is now just calculating it, whatever data they have. You were surprised before by that? You can imagine, and I've actually talked to Paul Tang, who's been on the Health Information Technology Policy Committee and the ONC. They said, we know you're going to be surprised by some of your quality measures when you implement, for instance, meaningful use, your electronic quality measures. That's okay. That's just reflection. You're just getting paid for reporting for this now. But a lot of places, as soon as that data's out there, they say, oh, I'm going to use this to judge the quality of care you receive. When your EHR is calculating the measure, it's totally dependent on your EHR, the way they want to set it up. And it's a lot of work to try and do this. And the other thing is, you're sort of solving a couple puzzles. First is, how is my care of this patient varying? But how is the EHR interpreting the care I deliver? How is it taking the data I have? And I'll give a quick example of that. I want to leave some time for questions. So the first thing we found out when we did it is the EHR wasn't actually telling. You saw in the previous slide, we showed people what was the hemoglobin A1C. In that measure, in a lot of EHRs, all they're required, did they meet or did they not meet a measure for a particular provider at a particular time? That's all you're supposed to report. If you're reporting in an aggregate, that's all you know about that is they met or didn't meet. And literally, they're not required to store this in a particular way. So, you don't know why they didn't or did or didn't meet this measure. So your informatics type problem solving detective work is a little bit harder than it was before in that one. Another one, and I hope Lori enjoys this example. This has happened to us. So this is standard SBIRT, the drug and alcohol screening form. It's actually got some depression screening on the top of it. So this is a very standard approach. And John Munch here, who's in family medicine with some other colleagues, basically got a grant to advance SBIRT screening. So get drug and alcohol screening in place, be early adopters, improve our quality as we go in. And so there's a whole bunch of aspects of this you could see. So you do an initial screen, this is depression, and then you do a full screen, so there's second screening, and then do you actually intervene to say, gosh, you've got I think you might have a problem with drug or alcohol. Have you thought about stopping or quitting, or which this, I'm not doing it well. I should model the right behavior for you. But the point is that all the steps are captured. And the way we implemented the measure, the way they did, we got basically sort of components of each. Did you do the initial annual screen on all the patients you saw in primary care? For those who had a bad score, who had a high, potentially concerning score, did you actually get more specific and give them the full screen? Great. And then did you intervene? Did you do the brief intervention on the people who did that? Great. Well, so we were getting 50 to 65% on our sort of initial screening and moving to full screening. So we felt like we'd really improved from 0% before, and then the CCO, the state definition of this, has a different measure which requires a billing code to be dropped that we never use. So our score is less than 1% all of a sudden. So it's we were very surprised by this. So these are sort of the lessons, and so then you've got to go back and retrofit, change some way, but you've already got a process that's working pretty well. So you tell all your clinicians, stop doing that, do this other thing instead. We tried that, did not work. So instead we try and get the EHR to reflect on our position. So I'm not going to spend much time on this, but I'm going to reflect on what Lori said, which is right now most EHRs are producing the electronic measures in a way that facilitates aggregate. They discourage you from doing the individual patient data, but that's where most of the aggregation happens. And they're supposed to have the data in the document to tell you about what happened. So I think things will evolve. Here's the Value Set Authority Center, which is I can send this out. But if you have a UMLS, you can go and look at what are the definitions of the various measures and pull up their value sets and look at what is the core issues. But so that's a really great thing. But the really difficult thing here at OHSU is because the EHR is now producing these measures, we've got to create a whole set of tables to define for ourselves what this quality measurement means for us to help us in our problem solving. Who are they seeing? Who is responsible for the broad clinical quality care? Are they part of a CCO panel, or are they part of a different panel, so that we can understand this. And this is just a snapshot of the additional data elements that we've had to create on top of what the EHR creates for us. It's actually still being developed now, so there may be more tables as we're going forward. But you've got to do a lot of work from the informatics side and the data architecture side to actually make good use of this, to use it for quality improvement. So you can't just say, oh, I'm going to flip the switch and it'll be good. If you actually want to use it for some of these efforts, you need to do that. So those are sort of, from an informatics perspective, what's the thoughts are. So maybe we'll just open it up in these last 10 or so minutes for questions for either Lori or myself. And please press the button. Yes, Bill.
I'm actually going to read a question from our Twitter feed.
Okay, good.
By someone we know well, Dick Gibson, who's listening in out there. And Dick's question is, what is the relationship of HQMF and VSAC to meaningful use stage 2? Is a lot of work required to morph meaningful use stage 2 reporting to these?
Well, I think there's a lot of work. It depends on how much time and effort you spent in putting in your initial meaningful use stage 1 electronic quality measures, if you really looked at that carefully, because really what this is doing, the VSAC just stores the concepts that are in those quality measures, the HQMF definition, the E quality measures. So in general, the approach has been for everybody is there's a set of electronic clinical quality measures that you're reporting for meaningful use through your EHR. Your vendor tells you, here's how we suggest you implement those. And you either spend a lot of time thinking through that and making sure you're mapping your current workflow to what they're expecting. and doing it, or you just sort of do it quickly because it's a lot of time and effort. And for all of this, the more time you've spent looking at actually what's going on to put the data into the EHR by your clinicians for these clinical quality measures and how that maps to what the EHR expects, that's going to pay off, basically. The more time you think about that and think, how could I best use that data, that information to drive my workflow, or how can I adjust the EHR implementation, optimize it, the better. So the QRDA does bring a unique component because I think that there's a sense that the EHR implementation of the QRDA patient level is sort of, it's there for test, but it's more in theory. It's implemented. They have the capability, but implementation of it probably is something that you have to look at and test to make sure it's good. And there's a benefit to that because then for your CCDA definition for any health information exchange, you're gaining that value as well because there's a lot of overlap between them. But a lot of places don't even think about this. They're just like, well, I'm going to hit a switch and send it out to them and it'll be fine. But you got to get that in and start testing it now because you're going to be surprised, I think. It's difficult. Dick is a good example of somebody who's an early innovator in quality measurement, right? So you're like, why are you making me adopt a broken process and reinvent what I did? And the point is that, I think there's a lot of optimization you can do as long as you test it. So.
Hi, Joe Fazio, Department of Pharmacy here at OHSU, Pharmacy Informatics. So really the question, or at least the inquiry I have around policy, around data origination. You've got plenty of EHR vendors, 97, but most of them 10. As far as the human-computer interface, capturing that information that's going to be needed for these measures, is there at least an effort into creating a structured way of capturing that data as opposed to a free text, or an automated way of collecting the data during the EHR use, whether it's nursing, pharmacy, or the provider? If not, are interfaces being designed in a way that it would be easier for the individual using the system to enter that information? And I guess for a policy from the provider side, what are we going to do to encourage that information to be consistently entered into the system so that we're not reporting on a 40% null for a particular field?
Yeah, I think that's a great question. So, in general, my answer to all of your questions is this is sort of the heart of informatics and related disciplines, to look into this issue. And now, sort of the value we could potentially add by looking at the workflow and the data as it's entered and the structured data. I mean, Espert's a particularly good one, I think, because it's a lot of questionnaires and data that might just be in the note. Did you screen them, yes or no? Falls screening, which is a new meaningful use measure used in some primary care improvement projects, is another one where people would say, I screened them for falls and put it in free text. And the question, sort of, can we develop a set of best practices around the way you do that? Because there's a ton of reworking from what we do now to what we're doing later. And how do we feed that back into the system so they realize where the error is occurring? I think you're really hitting at the problem solving that we have to do. The biggest challenge, I don't know if Laura, you have thought about this, is you sort of feel like, well, I'm already doing this, right? I'm taking great care of my patients, but all of a sudden it's not reflected anymore. It's a total surprise. And then, you get a little depressed and you say, gosh, I put all this great work into it. But, there's so much opportunity that comes along with that because we're shifting the way we think about encouraging people to do certain things in healthcare through our incentives, through just reporting those. I don't know if you have a...
So I can respond a little bit too.
Is your mic on?
Yeah, it should be.
I think I turned it on.
Okay.
as David mentioned, the collection, I kind of think of it, it's multi-step, but there's two main steps where in programs there have been problems. One is the technology and coming up with standards for how to transfer and the data, and then the other step is the workflows, which I think you're alluding to. So what happens is early on, I know of some states where they put together this great system for collecting the data. They looked at it and it was almost all nulls because the practices weren't putting anything in a structured field. So some of the TA resources that we're talking about providing from the state is to help both in the technology side, but then also in the workflow side. So and in some ways also, I think providers are going to need support from entities like the CCOs to build and develop workflows in order to make so the CCOs can get their payments. So there has to be some sort of collaboration and probably incentives for providers to do it right.
So I guess my summation of this would be our challenge is to, I guess, design ways to collect the information without getting in the way of patient care. Mm-hmm. Not, the ubiquitous computing not being a barrier between the provider and the patient.
Yeah.
Right.
I think that's right on, that there's a lot of work trying to understand how do we collect this more easily, more efficiently, because as the number of standards increase, so too do the costs of collecting the information. So we got to figure that out. I mean, Lori talked about one that's a huge cost, which is just chart review, right? So we're moving away from a big cost, but are we just pushing that cost onto other people as they're collecting the data? And we don't want to do that. We want to be efficient in our collection. We're a little bit short on time. I don't know if...
Maybe take one more question.
Yeah, maybe if we have one more question for Lori and myself.
Terry Cameron from Quality Corp. I'm just curious, is there anywhere...
Can you hold down the button on the microphone, please?
I'm just curious, is there anywhere in Oregon where the transformation to electronic health record reporting is working right now?
I guess I'd need to know more about what you mean by working. I think that, David, there are programs that are doing it, but not in any coordinated fashion. So, for example, in Rogue Valley area, that particular CCO has an HIE within just their network, and so they move data around pretty well, I think. But there are kind of nodes in the region where it works pretty well, and it's not all connected, and I don't know what.
No, I think that's good. There's these little points of light that exist where they're sharing data, but it's a chicken and egg problem, right? We don't have to submit the individual patient data right yet, although that is changing rapidly. That there has been some, there are quality measure initiatives that have been going on federally and other places that are clinical quality measures like PQRS and various forms of that system where people have been submitting this, and a lot of the places do submit it. OHSU submits all of those under their GPRO, but there's not a unified standard, so every one of those projects feels like a separate initiative. It doesn't feel comprehensive, probably in the way that you mean that it's working, that you're just like, oh, you want my quality measures for this? Here you go, right? And subset the patients, no problem. There's not that kind of, it's sort of, well, only on these patients, and for this reason, we got a slightly different definition, you can't use this. So I think that, the more the standards are, the more people will be ready to adapt to it, but, we've got this problem where they haven't been in place very long. And so we need to adjust to that. Okay, thank you so much. We can stay around for a little bit. Appreciate it.